Welcome to AETCM, the emergency medicine channel. Today I'll be presenting a case of a 69-year-old female who presented to ER with complaints of abdominal distension, abdominal pain, fever, breathlessness and reduced response. On initial 10-second assessment, patient is drowsy, not obeying commands. Primary survey, airway is patent, no gurgling sounds or stridor. Breathing wise, there was bilateral basal crepitations. Patient is tachypneic with respiratory rate of 32 per minute and saturation of 84% on 10 liter O2. Changed to NRBM mask and kept at 15 liter O2. Circulation wise, pulse rate was 163 per minute, BP of 90-50 millimeters of mercury.
Okay.
Capillary refilling time of 4 seconds. Or peripheral pulses were not palpable.
Okay.
18 gauge IV cannula was inserted, EJV was inserted with 18 gauge cannula and cardiac monitors attached.
Okay.
Cardiac monitor showing sinus tachycardia with a heart rate of around 150 to 160.
Fine.
We started on IV fluids initially because he has IV fluids with 1 liter NS. IV bolus was given. Disability
What's
wise,
BP? Sorry.
BP was 90-50 with a pulse rate of 163 per minute. And disability wise, GCS of E3, V2, M4 around 9 out of 15. And pupils were 2 millimeter equal but sluggishly reacting to light. GRBS was 109. Exposure wise, temperature was 101.4 degree Fahrenheit. And injection PCM 1 gram IV stat was given. Repeat BP we had taken which showed 80-50 BP. And we checked IVC which was collapsible with kissing IVCs. So we had again given 1 pint more fluid bolus. And we had planned to start inotrope support, noradrenaline, if the BP does not pick up after this bolus. We checked for LV also. LV was showing good LV function. Further, we had planned, since the patient was tachypneic and with reduced sensorium, to protect the airway, we had done a rapid sequence intubation with 8 size ET tube. We had given drugs etomidate 20 mg and rocuronium 50 mg. And with that, we intubated with 8 size ET tube. On laryngoscopy visualization, the patient had profuse secretions and we had suctioned it. And after that, we placed the tube, fixed at 19 centimeter angle of mouth. And after that, patient was also having secretions through the ET tube, coming out through the ET tube, so a sterile suction was also given.
Okay.
Patient was not able to achieve the tidal volume, so we had increased the respiratory rate and the pressures. Adjuncts of primary survey, ABG was taken initially itself when patient came at 10 liter O2 itself, and pH was 7.361, bicarb of PCO2 of 27.7 and PO2 of 63.6, bicarb was 15.3, lactate of 3.2, but create was 1.17. And we had also done ECG, 12-lead ECG, which showed a sinus tachycardia.
Okay.
And secondary survey, patient is a 69-year-old female with no known comorbidities. And she had undergone vaginal hysterectomy 4 days back for uterine prolapse from outside hospital. On post-op day 3, she had complaints of high-grade fever, which was continuous with associated breathlessness, which was gradual onset, progressively increased to MMRC4. She also had complaints of abdominal distension with a diffuse generalized abdominal pain. And bystander also gives history of progressive worsening of sensorium towards evening. And they went to outside hospital that night itself, and the supportive management, everything was given. And USG done from outside showed a heterogeneous parenchymal texture of liver with minimal free fluid in abdomen. And they referred here. There was no other history of any vomiting, cough, altered bowel, bladder habits, chest pain, or any jaundice history. No allergic to any medications, not on any regular medications, or no past history, significant past history, except for the vaginal hysterectomy done 3 days back for the uterine prolapse. Last meal was taken 2 days back. She was anorexic, so she hadn't taken since 2 days. On examination, patient is drowsy, not responding to commands. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Systemic examination wise, abdomen, GIT was soft to tense, it was, but it was distended. No rigidity was appreciated. Bowel sounds were sluggish, and chest examination wise there was crepitations in right inframammary, infraaxillary, infrascapular areas. And CVS wise S1 S2 was heard, no murmurs heard. CNS wise GCS was E3 V2 M4, pupils 2 mm equal sluggish. And our provisional diagnosis is we are suspecting a short.
So let us summarize at this point. So we have a 68-year-old lady who had recently underwent a vaginal hysterectomy. And immediate post-op period itself, she was having abdominal distension with abdominal pain and in due course breathing difficulty and altered sensorium, right? Yes. So with those complaints, she had presented to us. On arrival, the presenting complaints you told was again breathlessness, abdominal pain, right? And hemodynamically, you feel that the BP was slightly on the lower range, probably non-responsive to fluid is your initial input, and there was also lung findings in the forms of crepitations, and provisionally you feel that there is some amount of aspiration which should have happened, right? And because of these things, you decided to secure the airway. So an ET tube was placed and RSI was done, and during intubation also you felt there was some secretions and content in the ET tube itself, and there was some initial difficulty in maintaining adequate volumes and oxygenation. Post paralysis, that those things were also maintained. Post intubation again, BP remained low post IV fluids requiring inotropic support, right? Okay. On examination also, because here the patient is sensorium is not that great, so your assessment of perabdominal examination, the subjective things may not be elicited properly. Okay, so that caveat you need to always remember. Okay, but in all this background where there is a recent surgical intervention, immediately a temporal relation of abdominal distension and pain, so then obviously there are certain diagnoses you need to think about, right? So what are the differential diagnoses you are going to consider in this clinical setting?
We have to think of first we have to suspect.
So basically two things. One thing, you can connect it to the surgery. Second thing is independent of surgery. So let us go in those lines. So independent of surgery, what are the things you are going to?
Independent of surgery, patient might have had fever with LRTA, suspecting an LRTA infection, or an aspiration because of the progressive reducing sensorium. You can suspect an aspiration pneumonia as well.
So you are thinking about an independent cause which is decreasing the sensorium, and because of that aspiration. Okay.
And could
be a dysautonomia and things like that. Okay, fine. Right. Or a primary neurological issue. Okay, sure.
Connection with surgery, any related any perforation. Also, you have to suspect any peritonitis, secondary to surgery or post-op infection. Local cause for the infection has to also be suspected.
Okay. Right. So, because of a hysterectomy procedure was done, probably some bowel perforation would have happened, and because of that all these symptoms would have happened. Okay. Any other diagnosis you will entertain? Nothing else. Okay.
Further, we have increased since the BP was not picking up. We had started on inotrope support noradrenaline. We had started initially on 4 ml per hour at 10 mics per minute, and then progressively tapered, progressively titrated according to the BP. And the BP this thing
from a resuscitation perspective, here you are planning to start the patient on NORAD, right?
Yeah.
Would you insist on a central line at this point?
We can initially see if the patient is not requiring high dose of inotrope support, then we can initially manage it with the extra jugular vein cannulation.
So a wide bore cannula to start with is reasonably okay, but provided if the inotropic requirement is going up, definitely you will need to. Any other intervention you will
arterial line insertion for BP monitoring also.
Exactly. Since the patient is going upon inotropes, arterial line will be very much warranted in such kind of patients. Okay. So an arterial line was placed, you put in an EJV and started NORAD via the EJV. Okay. Anything else which is going to help you guide the resuscitation? You told about ABG, right? So.
Yeah.
Here, your resuscitation can be guided by two things, no? One is urine output and lactate. So, if the lactate is elevated, you can see whether the lactate clearance is happening adequately. Other thing is monitoring the urine output.
Right. So, if we had monitored the ABG wise after the resuscitation, the lactate repeat ABG improved to 2.6.
Okay.
And further, we had also given the first dose of antibiotic since the patient was in suspected sepsis with septic shock. We had to start antibiotic within 1 hour. So we had initially started on meropenem 2 gram IV stat, and we had also.
Okay, we'll stop there. So basically, you are suspecting. So your choice of empirical antibiotic will broadly base upon the focus you are going to suspect, right? right?
Yes.
So here, what is the focus of infection?
Either
you're
it
going to
can be
suspect?
the respiratory.
No, but
lung
by now we can
infection
rule
or-
out the respiratory thing. There is very much clear-cut evidence of recent surgery and all. So we will think in those lines at this point. So let us assume that we are dealing with an intra-abdominal infection, right? So intra-abdominal infection, what is your choice of antibiotics? And here you are going. Did you send the blood cultures?
Yes, blood cultures.
Ideal situation, you have to send for the blood cultures and then start on the antibiotics. If the blood culture is getting delayed, in a patient who is already in septic shock, you are justified in starting the antibiotics upfront. Okay, now we are coming back to the choice of antibiotics. So here the condition is critically ill patient in sepsis, septic shock with a suspected intra-abdominal infection. So what are the organisms you are going to suspect?
If intra-abdominal infection, we have to suspect the coliforms itself, intestinal flora, E. coli, Klebsiella, Proteus, or Enterobacter. To suspect, or else it can also include Streptococci or
Enterococci,
aerobes, then anaerobic organisms, Bacteroides fragilis is common.
Okay.
So these all coverage we will have to.
So that you are talking about if it is colon,
Yes,
or small intestine or colon. If it is upper intestinal, upper GI, what is the flora going to be different? So basically you are talking about esophagus or stomach. There you are not going to expect coliforms. There it is going to be more of aerobes or anaerobes. Additional thing you need to remember is candida. Esophageal candidiasis, everything is more common. No? So there, that will be, if it is an upper GI perforation or stomach perforation, definitely you have to consider those organisms. So which anatomical site you are expecting the perforation, that will also help in determining the choice of antibiotics. So here, as we correctly told, you are going to suspect more of coliforms, aerobes, anaerobes with these kind of organisms. Okay, now that is one thing. Second thing to determine the antibiotic will be
if it is community acquired or hospital acquired infection.
So here it is a surgical intervention probably which is the provocating factor. If it is community acquired, what is your choice?
Community acquired, we can start initially on gram-negative coverage with cephalosporins or fluoroquinolones with added anaerobic coverage with the metronidazole. If
you want monotherapy,
we can start on piperacillin.
Okay. What's the dose?
4.5 gram IV TID.
Q6 hourly. 6 hourly is in GR. Okay. So either you start on Piptas or a double coverage. Fine. That is a low risk community acquired. High risk community acquired or in hospital acquired. What's going to be your choice?
We have to again initially itself start on piperazine, tazobactam or meropenem if you are suspecting resistance also.
Okay. In our part of the world, basically in Asian countries and Southeast Asian countries, it is always better to cover with something broader. So your carbapenems will come into play at that point. Okay, fine. So tell Piptas. What are the various carbapenems which can be used in GI tract infections?
Meropenem or ertapenem.
Okay, meropenem dose?
Meropenem 1 gram IV TID.
Good.
Then
Imipenem? Not ertapenem, imipenem. Because ertapenem does not have pseudomonas coverage. Okay. Hospital acquired means you are suspecting pseudomonas will come into picture. So you start either meropenem or
imipenem.
Imipenem. Imipenem's last statin is again 500 mg Q6 hourly. Sorry, 8th hourly. Or doripenem. Doripenem again is 500 mg Q6 hourly. Okay. So these are the 3 carbapenems which can be used in intra-abdominal infections. Okay. So you talked about carbapenem. What else? If you are that is with the monotherapy regimes, right? If you are going for double drug therapy, for some reason you are not able to give carbapenems, then
cefuroxime or ceftriaxone with metronidazole.
Fair enough. Okay, fine. So, right, if the patient already has, say the patient was operated before, has already have a significant gram-negative predisposition and all, then probably you have to think about carbapenem resistant organisms also. So that's the situations where you are going to think about ceftazidime avibactam, those kind of antibiotics. The problem there is here we need not add anaerobic coverage. Once you are giving carbapenem or piptas, you are not adding metronidazole because that itself has anaerobic coverage. But if you are going for a higher antibiotic than meropenem like ceftazidime avibactam, that does not have anaerobic coverage. So in those kind of situations where you are already expecting an XDR or MDR or CRE organisms, where you are starting ceftazidime avibactam, you have to add on metronidazole for anaerobic coverage if needed. Okay. So that is with the choice of antibiotics in lower intestinal perforations. Okay. So here we have given what we start.
We start on meropenem.
So how will you give meropenem?
Usually we give stat dose as 2 gram.
I mean, in this situation, 1 gram is ideally more than enough, but fine. We gave 2 gram. How? Is it a stat, infusion, bolus?
Infusion, 100 ml
Over?
or 4 hours.
So basically, extended infusion protocols are recommended for antibiotics like this, carbapenems and your piptas and all. Okay, fine. Why?
Because time.
So these drugs are time-dependent drugs, not dose-dependent.
Dose-dependent.
So for a longer period of time, you want to maintain the inhibitory concentration levels. Okay, so you give these antibiotics as a longer infusion over 3 to 4 hours. Fine. So we gave meropenem 2 grams IV infusion over 3 hours. Fine.
Then further we had taken chest X-ray we had ordered initially,
Okay.
but the patient was lying down posture. So in that chest X-ray wise it showed right whole upper middle and lower zone haziness was there, and left only lower zone haziness was there. And but we couldn't see any air under diaphragm. Also the patient was lying only supine.
Okay.
And after that we had ordered an ultrasound abdomen which showed again the same, confirmed the same features itself. And we had seen a free fluid over the perihepatic perisplenic near the bowel regions, and also there was a isoechoic portion near to the urinary bladder towards the right side. So it was upper side fluids all were hypoechoic. So it was like ascitic type of fluid, but lower it was showing more of an isoechoic. So again we had further planned for CCT abdomen, and we had also since this.
Okay. In these situations, once you're asking for an ultrasound, you should be always aware of what things you can pick up in an ultrasound, what things you cannot pick up in an ultrasound, right? So here we are suspecting probably a perforation peritonitis kind of thing. So definitely air you are not going to see in your ultrasound, right? So basically we are looking for either free fluid, one. Second thing will be any obvious collections. Okay, perioperative site collections, those kind of things, definitely we can pick it up. Fine.
Then after that we sent all labs.
No, you are talking about the CT.
CT abdomen we had planned that time.
So why can't we just get away with a plain CT in this patient?
Site of perforation.
If you are suspecting perforation air under the diaphragm, all you need is a CT abdomen plane, no? Then why? Because even though perforation is just one of the diagnoses here, no? So we don't know about the alternative diagnosis. We don't know about the exact mesenteric ischemia. We may not be able to know. So if you are giving contrast, definitely you will get a better delineation of the organs. So you do a plane, you will probably see or may not see an air under the diaphragm or any other intra-abdominal site. With the contrast, you will be able to see if there is any collections about the vessels. Those kind of additional information is specifically needed because even a hematoma or a bleed could be a possibility post-surgery. So other etiology to rule in or rule out, you will need a contrasting agent. That's the rationale for contrast in this patient. Fine. Continue.
Then by that time lab investigations, we had done all routine investigations.
CCT report you can say.
Report. CCT report showed as diffuse circumferential symmetrical bowel wall thickening with mucosal hyperenhancement and mural stratification noted involving all the small and large bowel loops.
Okay.
So these are likely to represent, they have written as septic shock related findings.
Okay.
No features of bowel gangrene.
Okay.
Pneumoperitoneum is seen and also focal bowel wall defect, but they couldn't find out from the CT. And there is mild to moderate ascites with diffuse mesenteric stranding.
Okay.
And also they are also seen patchy hypoenhancing areas in right kidney, likely focal pyelonephritis. A bilateral mild to moderate pleural effusion and multiple patchy ground glass opacities in bilateral lung, likely aspiration related changes.
Okay. So here in post-op patients, a small amount of pneumoperitoneum is usually acceptable. Some kind of air leak would have happened, even though it is non-laparoscopic procedures and all. Some amount of air leak is usually anticipated in post-op kind of patient. But if the amount of pneumoperitoneum is disproportionate to what is the accepted norm, or you document a progressive increase, that is the situations where you need to think about a definitive role of perforation. And the problem with perforation is that it is not always that you are going to identify the site in the CT. You might get, if there is an obvious collection or abscess, definitely CT might pick up. But a small dent in the bowel may not be always picked up in the CT itself. Okay, so those are things, right? So here definitely it looks more like a perforation now, but we don't know the exact site of perforation, right? And you're talking about free fluid and local inflammation in the bowel wall at all. Again, some kind of peritonitis with inflammatory reaction could be a reasonable explanation for that in this clinical setting. The overall bowel edema is again another entity where you have definitive hypoperfusion related bowel wall changes. That can happen with septic shock itself. Okay, fine, good.
Okay, after that, investigations we are done.
Yeah.
Showed a CRP of 357, procalcitonin of 18.62, creatinine was 1.49, minimal AKI was there, and INR was deranged 2.17, and platelets were also reduced 1.16 lakhs, and the total count was 1.98, 1980.
Oh.
So there is a
With
more
neutrophilic, or what is the breakup? So
breakup
whenever you see a
61%.
so whenever you see such a low count, always go for the ANCs, right?
If there is a neutropenic, we'll have to.
Yeah, what is the ANC here?
ANC will come as 61% of
61% of
to 1.98.
1.98. So no problem. It is around 1000. Okay. Then
Around 1000.
yeah.
And HB was showing as 14 only.
Hemoglobin of 14.
14. Hematocrit of 43.
Hmm.
Then further they had a planned, we had called GA surgery, and they had taken up for exploratory laparotomy, emergency laparotomy, and emergency laparotomy findings. It showed a ileal perforation of size 0.5 into 0.5 centimeter,
Okay.
at around 70 centimeter proximal to IC junction,
Okay.
and there was also purulent ascites of around 350 ml, and rest of the solid organs bowels are normal, and they had again further planned for the resection of the perforated ileal segment of size around 40 centimeter with end ileostomy.
Oh. Okay.
Patient while in ER itself, patient was progressively deteriorating with increasing in the inotropic support, and desaturation was also progressively occurring.
So post-op, you have any idea how she is?
Post-op day 1 only now.
Okay. Okay. So it's anything else?
So the progress.
Okay. Okay. So more or less a straightforward case of a post-op perforation coming with significant perforation, peritonitis with intra-abdominal infection leading to sepsis, septic shock, early pickup in the ER itself, and patient was taken up for immediate surgery. And now it's more of like a post-op recovery period. The patient had ended up in ileostomy because the defect probably could not be in situ repaired. So ileostomy has been done. Right? That's what you are told. Fine. So what are the possibilities? Like, it's not always that a small nick in the bowel can lead to a complete peritonitis perforation kind of scenario. What are the other possibilities of a perforation?
Other causes.
Not causes. So once a small perforation can happen, it can either be a concealed perforation or it can go into a peritonitis kind of situation. A concealed perforation is where with a local inflammatory change, it gets sealed off by itself. And a small abscess might form at the perforation site. It is not always that. Here what has happened, the bowel contents have come out into the peritoneal fluid. And from there it is causing peritonitis, bacteremia, these migrating into the bloodstream and causing infections, right? Because all these bacteria are always in your gut. More than 400 plus bacteria might get types of species of bacteria can come out, right? So out of this, there are certain pathogenic bacteria which are causing the problems here, right? So at the same time, instead of peritonitis, it can end up as a localized kind of an abscess formation at the site also. That is the other possibility. Especially this peritonitis and all these things can happen in, there is risk factor scoring, no? There is patients, elderly, diabetic, immunocompromised, those kind of patients, there are higher chances of this going into peritonitis. Okay. Here, definitely it has gone into peritonitis and an early intervention has been done at this point. Okay. Anything else?
Then further other causes for perforation.
Yeah,
also it can either be due to a traumatic cause, or as in this case, instrumentation, secondary instrumentation, endoscopic procedures, or any cautery during surgery, also it can occur. Then other causes like bowel ischemia, or any bowel obstruction which further leads to ischemia. And there is a bowel obstruction, there will be increase in the interluminal pressure proximally, and this will cause ischemic changes and necrosis and further perforation. Then or any other neoplasm causing obstructions here, colon, like that. Or even in inflammatory bowel disease, Crohn's disease can also present as perforation. Then other peptic ulcer disease, perforation, or any medications or corrosive induced.
Okay.
Medications can either be due to the obstruction causing secondary to the medication intake. Then other causes, infections can also cause. Typhoid can cause perforation. TB, gastrointestinal TB, schistosomiasis can also cause. And
so it is usually your organisms like we told about, coliforms and gram-negatives. Those usually lead to peritonitis kind of formation with a fulminant cause. Your chronic things like tuberculosis, those kind of things usually will form abscess and it will be a slower kind of a growth. Fine.
Then after that, other causes like appendicitis, that rupture, or any gallstone causing gallbladder perforation, or any other diverticulosis, colonic diverticuli causing diverticulosis and perforation, or any retching, like if the patient is having repeated retching and vomiting, then it can cause Boerhaave syndrome, lower esophageal perforation. Then other, based on management wise also, we can either go as conservative management or we can go with surgical management based on the patient's presentation. So if there is any contained perforation or any fistula formation as such, or any limited contamination, that is no evidence of any sepsis or multi-organ dysfunction is there, then we can try for conservative management. Usually seen in like perforated esophagus cases or any diverticulosis, appendicitis patients, such patients, they have tried, usually been tried this conservative management and it has been successful. And surgical, if there is any evidence of any sepsis as in this case, or any diffuse peritonitis features, bowel ischemia, or any obstruction, complete obstruction, and all we have to do, manage surgically.
Since you told about conservative and surgical management, what is the duration of antibiotics in
conservative?
So basically, the thing is that if you are going for a definitive source control, so in our patient, we have gone for a source control and we feel that the infection is reasonably controlled. We went in, we cleared up the abdomen, the infective site is cleared off, there is not much pus, there is not ongoing oozing and all. So in those kind of situations, you can go for a shorter duration of antibiotic. The trial was called a STOP-IT, S-T-O-P-I-T trial. So in that trial, it was found that close to 4 to 5 days of antibiotics is enough, provided you attain a good source control. So in situations where the source control is not optimal, you have ongoing drains, drain has been put in and pus is draining, or else the surgical management is not feasible. In those kind of situations, definitely a longer duration of antibiotic is recommended, at least 10 to 14 days. But again, depending upon liver abscess, solid organ involvement, and if there is a liver abscess, then probably your duration is going to be 4 to 6 weeks. So depending upon the site, depending upon whether a source control intervention is being done, and the progress of the patient, you will need to tailor the antibiotic course. But always remember that if there is adequate source control, then probably even a shorter duration of the antibiotic, which we chose based upon whatever initial discussion we had, site and type of organism we are suspecting, etc., can be given for a short duration of time. Okay. Anything else, anybody? No. Okay. Thank you.